The Undisclosed Alternative: Vitamins, Anticoagulants, and Stroke in Atrial Fibrillation. Presented by Nitin Raganti and Nicholas Vu, as well as our mentor, Dr. Scott Yates. Introduction. Direct oral anticoagulants, also known as DOACs, are first-line therapy for stroke prevention and atrial fibrillation, but optimal risk reduction requires strict medication adherence. Patients often use undisclosed alternative therapies, leading to unadvised discontinuation of prescribed DOACs. Stopping standard treatment without medical guidance drastically increases stroke risk, often resulting in severe clinical outcomes. Our case: a 70-year-old male with a history of atrial fibrillation, hyperlipidemia, gastroesophageal reflux disease, and benign prostatic hyperplasia stopped apixaban, a DOAC, several months prior to presenting to the clinic on the advice of an alternative medicine practitioner in favor of vitamin supplementation. In February 2026, he experienced a fall with loss of consciousness, which he attributed to a concussion. Brain magnetic resonance imaging demonstrated a right posterior cerebral artery, aka PCA territory infarction. Please refer to Figure 1 for an image of what this may look like. He was then admitted and evaluated by neurology, and apixaban was restarted. Approximately 3 months later, following a consecutive days of Gulf and hot weather, he developed a week of generalized weakness, prompting him to seek care and get IV hydration at an outpatient clinic. A CT scan was performed at the clinic, showing a very similar infarction as before, which prompted his diagnosis of chronic right PCA territory infarct. He was then transferred for higher level care and endovascular evaluation, during which the stroke team concluded that there was no extension of the prior infarct, and heat injury felt unlikely to explain the breadth of his symptoms. As he reported consistent adherence to his apixaban since resuming therapy, this presentation was thus attributed to the prior cardioembolic PCA infarction, leading to a chronic presentation of the initial infarct. On outpatient assessment, soon after this diagnosis, when we saw the patient, he presented as alert and oriented, but demonstrated clear cognitive impairment in an informal clinical examination. Specific deficits included disorientation to the day of the week, difficulty navigating familiar buildings or locations, and difficulty following conversations during meetings. Although these deficits were identified clinically, rather than through formal neurocognitive testing, their severity and functional impact were clear. Please refer to Figure 2 for a summary of the timeline of events that this patient has gone through, including the treatments, discontinuation of DOACs, and the presentations to clinics. In conclusion, atrial fibrillation nearly triples the risk of post-stroke cognitive impairment, while adherence to oral DOACs protects against both recurrent stroke and secondary dementia. Undisclosed complementary and alternative medicine quietly undermines adherence to evidence-based anticoagulation, which may create preventable risks. Proactively initiating non-judgmental dialogue about supplement use from the clinician to the patient can surface competing medical advice before harm occurs. Routine inquiry into alternative therapies seems a promising way to preserve shared decision-making, safeguarding patients from preventable cardioembolic strokes and subsequent cognitive decline.